5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate you all being here with 2 vote series disrupting the committee. It's tough as witnesses, and I do appreciate your patience. Let me echo what my colleague just said about the Stark Act. I think it's outdated probably in more ways than most people do, and I find it inhibits some collaboration in rural areas where we're underserved already, and why would we put barriers up? Does anybody disagree with that statement? I'm looking at the entire panel just for the record. None of them disagrees with that statement. All right, let's see. Given that, and now I've got a question that we want to get on the record. On June 29th, CMS allowed MIPS participants to see their performance score based on 2017 reporting. Would each of you please share what your scores were?
I'd be happy to start since I brought mine with me.
All right, that'd be fine.
We bill under 4 tax ID numbers because of how we're regionally divided. 3, we scored 100, and on the 4th one, we had a 97.
Okay. Anybody else weigh in who knows? Yes, sir.
I like your question because it also relates to the previous issue of physician participation. I was in a big group practice, and I decided to start my own practice. And so it was end of 15 and into 16 that I was doing that. The 2017 measurement, which you're asking about, is based on your surgical volume or your volume at the end of 16. But that's when I was starting my practice. I knew, of course, about our Academy's IRIS registry. I knew myself. I knew that I could do a good job on those measures, but there was no opportunity for me to participate. I couldn't opt in. I couldn't believe that I couldn't opt in, so I asked multiple people. I'm like, are you sure I can't opt in? I would love to do this. This is great. That's a good measure. Multiple people assured me I could not. So unfortunately, I was not eligible, even though I wanted to be.
All right.
As I've said before, we bill under a single tax ID number, and we did get 100.
Okay. And last but not least.
I'm retired from practice, so I'm dodging it.
No data. All right. I appreciate that. Thank you so much. My concern, of course, is rural areas, as I mentioned before when I was talking about the Stark Act. So when we're looking at rural areas, can you describe or can any of you illuminate us on the challenges of physicians practicing in the rural areas and the pressures they face to remain in practice, and how did the legacy programs add to those burdens? I mean, I know a lot of the burdens they have already, but how did the legacy programs add to those burdens? And has MIPS eased those burdens? And even if it's eased them a little bit, what else can we be doing to help our rural friends? Go ahead, Dr. Barbie.
Maybe I'll weigh in on that first. So I was amazed when MACRA passed and we were looking at MIPS, and we had a lot of physicians come out of the woodwork and say, oh my gosh, how are we going to comply with MIPS? And I thought in my mind, well, have they not been doing the legacy programs already? And the answer is no, they hadn't. Hundreds of thousands of physicians didn't participate in all 3 or didn't participate successfully. So there are a lot of physicians that are now working to make this transition. Specifically with regard to rural, Dr. Opelka said it very well. We need meaningful measures that relate to that individual physician's practice. We need to make them easy to capture, and we need to make them, if you will, activities that are applicable across more than one of those dimensions of MIPS. If you've got a diabetic patient and you're changing your processes and you're improving care and you're using electronic record, why don't you get credit across all 3 domains?
All right. Yes, sir.
Very quickly, the trauma program is a classic example where we have level 1, 2, and 3 levels of service. Typically in the rural environment, we're dealing with the level 3. The number of standards they need to meet are significantly less than the 200+ standards for a level 1. So you need to tailor measurement down to the point of care and the care model that environment has. The MIPS program does not do that. It's a one-size-fits-all program. So the rural element is no different than in surgery, is no different than in the city. They're not meaningful and fit for purpose. And therefore, the surgeons pay attention to it for purposes of payment, but not for the purposes of quality of care.
Okay. Anybody else?
We
Yes,
operate many rural clinics, but because they're part of a larger multi-specialty group, we're able to spread our infrastructure more efficiently to them. And to your other question about was it easier under MACRA to submit versus the legacy programs, I have talked to our quality department. It was slightly easier this year to submit to CMS. The mechanism of submitting all three at once was easier than the previous legacy format.
So it's a little bit better.
A little bit better.
Yes, sir.
I would echo all of these comments. Understand that rural medicine is very different than urban, suburban. And I know Washington, oftentimes people talk about a bubble in Washington, but coming from central Pennsylvania, it is a very different environment here. I mean, let me tell you, there are hospitals where I can't get internet service. I mean, just think about that statement. And my EMR, of course, is a cloud-based EMR. I mean, this is a true issue. But again, I think MACRA has certainly helped to answer the second part of your question.
Yeah, and other parts of our committee are trying to work on those internet issues. Dr. Razanoff?
I mean, technically right now, for someone who had just done nothing, MIPS is actually better just by the algebra of it initially because the cut would have been less. But I agree with what my colleagues and I've said previously. I think for small practices in rural areas, they just need a difference. They need relevant standards that resonate with their practice, but they probably need to have a different test so that they can participate. Fewer measures, I think, would be a very reasonable approach.
All right. Thank you very much. I appreciate it, and my time is up, and I yield back.
Thank you. Gentleman yields back.